Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
You got it. Good morning, everybody. Thank you for having me. So like Nora mentioned, I am a movement disorder specialist. I started out at Banner Sun Health Research Institute in 2013 as a new graduate from my fellowship training at Barrow. And I have been there for the last 11 years. We certainly are a smaller institute, but like Nora said, definitely world-class. Not only do we treat clinical disorders such as Parkinson's disease and other movement disorders, but we are also a center of excellence for Alzheimer's disease, and we have physicians who work alongside me to treat Alzheimer's. The other portion of our institute is one of them is the brain and body donation program that you heard about, and that is incredibly crucial to continuing to make advances in science. We have universities from all around the country who rely on our brain bank for tissue samples as they conduct their research, and participation in that has been an important part of the sort of advances that you are seeing in the current time, which eventually goes on to benefit all of us. And then we also hold clinical trials. So for example, one of the clinical trials we held starting in January of 2020 was of a drug, a new drug for Parkinson's disease. We were the phase 1 center for that, meaning it was the first time they were trying the medication out, small samples initially, and that grew to a phase 3 trial. And it's a subcutaneous version of carbidopa-levodopa, which I will explain a little bit more about. Well, the drug was approved 2 weeks ago by the FDA, and it's going to be incredibly life-changing for many of my patients with Parkinson's disease because it's a brand new way of giving medication to a Parkinson's patient. It's the first subcutaneous therapy in the United States. The European councils, if you may, and Canada approved it last year. But for us, it was a little bit of a longer fight to get that drug approved, and it was approved 2 weeks ago. So I will talk about Parkinson's disease today. It is something that I have spent most of my career on. I'm a movement disorder specialist, so of course Parkinson's disease is the biggest part of what I do. I also have a practice which is very busy with deep brain stimulation surgery, which is a surgery in which electrodes are placed into the brain and they help with Parkinson's symptoms. So I will discuss that a little bit more too. I'd be happy to take your questions at the end. Okay, so what is Parkinson's disease? So in Parkinson's disease, I'll just kind of let you read through this. It's involuntary tremulous motion, lessened neuromuscular power in parts with not in action and even when supported. So this kind of gives us a really brief overview of the changes that can happen with the body that are involuntary, that occur with Parkinson's disease. And they're tough for most patients because not only are you aging with time, but then there's this, neurological condition which is taking away some control of how you can move and manifest yourself. So Parkinson's disease is the second most common neurodegenerative condition in in the world right now. It is the second most common neurodegenerative condition secondary to Alzheimer's disease. Currently in the United States, we have about 1 million patients who have Parkinson's disease, and it is thought that perhaps between 60 to 80,000 new diagnoses per year. So the first question people ask is, wow, that's a lot of people. Why is that happening? And I would say that the most common reason would be that we have a healthier, in a way, or at least longevity-wise, people are living longer. So it is a condition which affects us as we get older. The known environmental factors can be pesticides, insecticides, exposure to Agent Orange, growing up on well water, because there's seepage of insecticides and pesticides into that. But 90% of the time, we don't know why people have Parkinson's. 10% of Parkinson's is hereditary, meaning it runs in families, and there can be genetic testing that can be done. But when I talk about genetic Parkinson's, it truly is a very prominent family history. You'll have more than a couple of people, probably a parent, a grandparent, some aunts and uncles, and the Parkinson seems to run in the family, and in those cases, genetic testing is helpful. But typically, we don't do genetic testing because it is thought to be sporadic or idiopathic Parkinson's disease. So that we also do expect that Parkinson's disease is going to double or triple over the next 10 years, and again, it's because there's easier ways to diagnose. And also, people are living longer. A lot of patients come and say, I think we might have had a family member who was shaking, in the 1960s, but they never received a formal diagnosis. And I think with education, especially in primary care, this is becoming more and more common. And why is it important to diagnose it? The reason to diagnose it is because treatment options are phenomenal. The Parkinson's disease of perhaps your grandparents or even my grandparents isn't quite the same as what we are able to do for our patients now. So we do need that diagnosis so that we can improve the quality of lives of our patient and allow them to live a healthy retirement. The incidence, like I talked about in the United States, is about 1 million, and worldwide is about 10 million for Parkinson's disease. The typical age of diagnosis is about age 60. Of course, there are patients who we call early onset Parkinson's that can have the diagnoses or have symptoms of Parkinson's in their 30s. Michael J. Fox is one. He was diagnosed with Parkinson's, I think, age 34 or 36. So when he was on that show, I think it's called Family Ties or Family Matters, he actually was already diagnosed with Parkinson's disease. The older you are, the greater the chances that you are going to have Parkinson's disease. So we do expect about a 30% increase in the diagnoses and incidence of Parkinson's by the year 2030 or so. So what really happens is that there's an area in the brain called the substantia nigra. The substantia nigra is what has melanin-producing dopaminergic cells, and in Parkinson's disease, the activity of this is lesser. Because the activity is lesser, there's lesser dopamine. Dopamine is a neurotransmitter. It's kind of like our feel-good neurotransmitter. It is released throughout the day, the greatest surge of which is usually in the morning when we wake up, but then throughout the day when you do something you enjoy, you're exercising, there are little surges of dopamine, and so that's the normal. That's like the normal what happens. But in Parkinson's disease, because there is lesser dopamine, patients will have lesser what we call motor activity. So motor activity directly correlates with movement, and so movement becomes slower, and it's because of the lack of dopamine. It's almost like you can think that the body is moving in slow motion because the go signal to the brain, from the brain to the body, is interrupted because of a lack of dopamine. Does that make sense? It's like the brain isn't producing enough dopamine, so the body isn't getting I want to be able to move, I want to be able to go. Playfully sometimes tell patients, dopamine is kind of like the gas in your gas tank. Your car cannot go without the tank being full. We have to fill up the tank, and in our case, we're trying to fill it up with dopamine. Now, of course, excessive dopamine can be problematic too, but we won't go there yet. But we need to have enough dopamine in your system to make your body go, just like the car, not an electric vehicle, like the typical old automobile needs gas to go. So if you look at slide number 10, or the one underneath the pathophysiology one, you can see the normal substantia nigra. At least mine is colored, and yours is too. I think most of us have that, okay? So the normal one, you can kind of see the brownish pigmentation over the substantia nigra. And then if you look at the little diagram underneath it, you can see how much paler it is. It's almost like a grayish in color. That's where those are the dopamine producing cells that have gotten lesser. And this is way deep into the brain. So imagine having a cut section through like my eye level here, and then going like not on the outside, but deep, 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 deep into the brain. And that's where this substantia nigra sits. And where the dopamine producing cells are. So we are going to move to the next page, to dopamine pathways. And you can kind of see here, and we don't have to discuss this in too much, but like what the dopamine pathways do, and they function with reward, motivation, motor functioning, like I talked about the GO neurotransmitter. Sometimes if it's too much dopamine, and that can cause compulsions, and perseverations, and impulse control disorders, even mania. Again, not something we have to worry about too much in Parkinson's disease, but it can happen if some of the meds are too much. Patients can become paranoid, compulsive. So that's why it's important to have a physician who knows what they're doing with your medication, because too much of a good thing can be a problem too. And then if you look at the serotonin pathways, they're just as important in treating Parkinson's disease as the dopamine pathways are. So the serotonin pathways, serotonin is a neurotransmitter as well, and that one helps with functioning of mood, memory, sleep, and all of like that kind of stuff. I liken, and a favorite analogy of mine is likening the neurotransmitter to spices, only because I love to cook. And I would say that to me, at least when I'm looking at a patient, these neurotransmitters are like, you know, spices or ingredients in a meal that are missing. If there's too much salt, it's going to be bitter. If there's too little oregano, it's just not going to have the right flavor. And my job as a doctor, as a movement disorder physician, is to figure out what are the ingredients you need and how do I balance those out. So how much dopamine sprinkles do we need? How much serotonin sprinkles do we need? Do we need more acetylcholine, a little bit lesser acetylcholine? That is my job. So as we age, our balancing changes, and that's the job of us. That's our job, is to figure out how do we balance your brain back so that you can be, you know, the best version of yourself that you need to be. And if you think about it like that, then you're not quite as afraid of medication, because a lot of times we have patients who come through and they're like, well, we don't want more drug. You're adding more medication. And I'm like, well, here a second. Like, hold on. It's sprinkles. It's a sprinkle of this and a sprinkle of that, and they both have different functions. And because of the different functions, we need a little bit. So perhaps if you think about it like that, then it won't be quite so overwhelming. So we're going to talk about Parkinson's disease symptoms with page 6, at least for me, and slide 12. And there, it's a figure of two people, and then you can see the figure of the gentleman who is stooped. And so let's kind of talk about what does Parkinson's look like on the outside. So as you can see on that slide, you can see that the gentleman is stooped postured, has changes in facial expression. So facial expression in Parkinson's disease becomes more blank, lesser animated, and a lot of times, you know, the husband or the wife will say, oh, you're not laughing as much, you're not as interested in what I have to say. And it's not that the patient isn't interested, it just the blank faces, it's called a masked faces. That's a part of the Parkinson's disease. With treatment, it does improve. It doesn't come back like the way it used to be, but patients do become, that's one of the ways I know that it's going well, is if they're a little bit more animated. Blink rate can be lower, you just don't blink your eyes as much, which can also cause irritation of the eyes. So then there is rigidity, and this rigidity is different from arthritis. The arthritis is more like bony, whereas rigidity feels more muscular. So patients say that, oh, we might have trouble getting out of a chair, out of the car, turning over in bed, those kinds of things. And then slowness of movement. So remember that your dopamine is your GO neurotransmitter. So everything looks like you're moving through water or in slow motion. Getting ready in the morning can take longer. Putting on your shoes, you know, just bathing, day-to-day activities, everything is slower. And again, when we treat the Parkinson's, that gets better, and people are able to, if not go back 100% to their previous activity, about 70 to 80%, which can be more than enough to get, to carry on with life. When you're walking, people tend to shuffle, and that can be frustrating for both the patient and the spouse, caregiver, family member. It's like, pick up your feet, but the patient cannot pick up their feet. It's hard to pick up your feet. Your body kind of loses its natural cadence. So I always say, let me do the nagging here, and you just tell on the patient. And with physical therapy, with sometimes using like a hiking poles, you kind of bring that cadence back. So the shuffling gait is again a big part of Parkinson's, and that your patients may also have freezing of gait, which kind of looks like wanting to go but getting frozen to the ground, like your feet are stuck to the ground, or we call a start hesitation. You've been seated for a long time and get going again, and in that time it is hard to get going, so there's like a stutter step almost. Arm swing can be reduced on the more affected Parkinson's side, and that's where if you have maybe not a walker, but if it's earlier in the Parkinson's disease time, we can use hiking poles kind of to force the body to move both sides of the body. Patients may have a rest tremor. A rest tremor is when your hands are completely relaxed in your lap or on the side of a chair, not being used, and then there's a little bit of a shake. It could be a little bit of a shake, it could be a lot of shake. And in those cases, again, medications are helpful, or a combination of medications can be helpful. And we talked about the gait. So that is all the physical manifestations. People can drool. Difficulty with swallow. So those are all physical manifestations. We're going to move to the non-motor, what we call the non-motor, and that's kind of like this second diagram, but it's not a very good one. So I talked about the four motor manifestation: tremor, slowness, stiffness or rigidity, and then postural instability I did not talk about. So postural instability means lack of balance. It's an intrinsic part of Parkinson's disease. It's a pathological portion of it. You really do have to work on how to improve your balance, and that's a tough one for most patients because it requires PT, activity. There's no drug, there's no medication to fix the balance, as much as I wish there was. So that requires a little bit more work, but it is definitely a big part of Parkinson's, and that's what causes the falls. We can work a lot with the slowness and the stiffness to improve balance, but that isn't going to be the entire picture. And then if you talk about the non-motor symptoms of Parkinson's, I think this is just as important as the motor symptoms of Parkinson's. So this is where your cognition comes in. Typically early in the disease state, patients will not have dementia unless you're much older. And that, I mean by much older, like, 80, 85. Like, we don't typically expect early dementia unless there's other factors at play, like, vascular disease and other things, depression. But typically we don't expect in the first couple of years of Parkinson's that you would have significant memory issues. But certainly after 5-8 years, and depending on your age, we expect changes in concentration, which then affect, memory with remembering the honey to-do list, for example. And then people can have visual hallucinations depending on medication, or just it's a natural part of Parkinson's disease. Some people can have delusions, and we have to, again, be honest and talk to your doctors about that so that we can treat these conditions. Sometimes just knowing that they're there and they're not harming you is enough. We don't have to treat everything that comes forward. You just, reassure the patient. So that's part of the non-motor memory portion. Then there is a diminished sense of smell. 70% of patients who have Parkinson's disease have a low sense of smell or absent sense of smell. This can exist 10 to 30 years before Parkinson's even sets in. So that's something that's quite interesting, and we don't know entirely why that is. It's thought that the olfactory nerves are involved in Parkinson's disease. Then there is dream enactment behaviors, which is talking, kicking, yelling while you're sleeping. So you're sleeping, and in that typical stage, you would have lesser dreams in the stage called REM sleep, or at least if you're having vivid dreams, you don't talk, kick, yell, act them out. But in Parkinson's disease, up to 70% of people will act out their dreams. Both of these conditions, lack of sense of smell, dream enactment, and constipation, can both exist decades before Parkinson's shows up physically. So we call them pre-motor symptoms. Before the physical manifestation happens, we can see these three. So if you are somebody who has something of these conditions, we've had clinical trials at our institute to kind of follow people through time to see what happens, how does this manifest, what changes. And it's a really, really important part of research. And then there is, some patients may have, I wouldn't call it pain per se, but it is, dystonia is painful. Dystonia is involuntary cramping. Usually happens when medications are not working very well, and that's why these new drugs, which give us more constancy, are such an important part of treating. Dystonia, we also use botulinum toxin, depending on where the dystonia is. A lot of my patients have toe cramping, like toe curling, and it's really painful. So we inject Botox. I won't say where, because then you won't want to come see me if you need to. But it's not that bad. It's not that bad, I promise. And then anxiety, depression, apathy, fatigue. I think apathy is probably the hardest. It's kind of like this nonchalance, this I don't care attitude, which I think is very hard for the family member to live with. And then we have the softer voice, trouble with choking and drooling, and low blood pressure. So in certain conditions, low blood pressure can be a big deal. So this is kind of what we talked about, what's on the outside and then what's on the inside. And you can see how much of Parkinson's doesn't really show up. You have to keep an eye out on it. You have to kind of be mindful. And that's why when we are seeing you, we have longer appointments so that we can really get to fix some of the things under the iceberg, because that is part of what is also going to help you live a better life. How is Parkinson's diagnosed? Parkinson's is a clinical diagnosis. It is a physical exam-based diagnosis. However, with the advent of modern science, we do have certain tests that we can do, one of which is a DAT scan. It's a scan kind of like a CT scan. You're given a ligand, like an injection, and then it goes up through the brain and it helps us see the dopamine transporters. So I'll show you a picture of a DAT scan. So this is a person who has Parkinson's. You can kind of see that side in which you see two bright commas, and then on the other side you have little dots. And that's the lack of the dopamine transporter. So we cannot measure dopamine directly. It's too volatile. It goes up when we're happy, comes down when we're not so happy. So it's too volatile to measure, but we can measure dopamine transporters. So the more dopamine transporters, kind of like a big city. If you have a lot of cars, if you have a lot of people, you'll have a lot of cars. So these are the cars. We have lots of dopamine, we'll have more transporters. So that's a normal picture. And then the other one is somebody who does not have enough dopamine, and that's the dots. Okay. And then many times we also use this scan if a patient has a lot of tremor and we want to differentiate between essential tremor and Parkinson's disease. In essential tremor, the DAT scan will be normal, and in Parkinson's disease, the DAT scan will be abnormal, as you can see there. I won't touch too much, just for the sake of time, about atypical Parkinson's, but many patients can look like they have Parkinson's disease, but it's not Parkinson's disease, idiopathic Parkinson's disease per se. We call them Parkinson mimickers. So these are patients who have early falls, early memory involvement, may have other conditions like severe blood pressure issues. Let's see. It's like Parkinson's disease with other symptoms, and the management of these are different. So there's 4 of them that tend to mimic Parkinson's. One is Lewy body dementia. So like I mentioned earlier, Lewy body and Parkinson's are technically separate conditions, a lot of pathology in common, but in different areas of the brain. Then the other one is PSP, progressive supranuclear palsy, in which patients fall very early. Within the first 3 years of disease, they start to fall backwards specifically, along with having eye changes, so inability to look upwards or downwards, usually after 3 years of the disease. Everybody's testing their eyes. And then there's multiple system atrophy, a condition in a little bit of a younger patient typically. family, in which there's lots of blood pressure issues, heart issues, severe constipation. Just the patient looks different. So these, and then corticobasal degeneration, in which there's significant dystonia and sometimes an inability to use your hands because of the connection between the basal ganglia, where the dopamine cells are, and the cortex, the upper part of the brain. That connection is very interrupted. And so, again, it's important for us to, have a full exam so that we can appropriately treat a patient and come to the correct diagnosis and then appropriately teach a patient. So Michael J. Fox, like most of you know, he has been instrumental in raising awareness about Parkinson's disease. And, being from a research institute, I mean, his contribution towards Parkinson's has been enormous, not just with fundraising and ability to have more knowledge about it, but also being very open about his own journey and kind of normalizing that, you can live a pretty good life with Parkinson's. So, all right, we're going to move on to medications. So Parkinson's disease, we have the grand stay is levodopa, carbidopa, levodopa, with levodopa being the active ingredient. Those are the pills. That's kind of what they look like, but we have some new ones. One that was just released about 10 days ago. So the stay of Parkinson's disease is carbidopa, levodopa, with carbidopa allowing levodopa to cross the blood-brain barrier and levodopa converting to dopamine. So we're actually replacing dopamine that the patient doesn't have. The problem with levodopa is that as the disease progresses, it's not that it stops working. It just doesn't stay, the patient's requirement increases, and levodopa, the way it's currently available in many forms, doesn't stay in the system long enough, which is why we are going towards more extended release drugs. One that was released like 10 days ago. There have been two recent ones, Crexont, which is an extended release carbidopa, levodopa, and then the subcutaneous pump that I mentioned. With the subcutaneous pump, you have like this micro dosing of the levodopa, which helps to maintain steady state. And if that sounds confusing, I can answer that. We have other drugs that this is like for one of these, is the MAOB inhibitors. Those are extenders. So again, a lot of effort has been placed over the last couple of decades on how do we make levodopa stay in the system longer? How do we get this drug to last more than 4 to 6 hours, sometimes 2 to 3 hours if the Parkinson's is advanced. This one you might not know about. It's called Inbrija. It's an inhaler. It's kind of like a rescue drug. I'm sorry, I'm moving fast. We have timelines here. So I'm happy to answer later, though, if you guys need anything. So this is a lovely inhaler that you'd kind of just, your patient is low. You need something to kind of perk you up. Take a couple of discrete little inhaler, take a couple of puffs, kicks into the system in 10 minutes. It doesn't last more than an hour or so, but it might be enough to get you through that holiday party or a dinner that you're going to. Again, our goal is how do we make day, be as smooth as possible. This is an intestinal gel that, again, is microdosing, continuous delivery, in patients who are having higher needs of levodopa now, a more advanced Parkinson's patient. So the pump is attached through tubing, kind of like a feeding tube, into the second part of the intestine called the jejunum. So it bypasses the stomach, so patients don't have to worry about food, can eat normally, oral foods normally, and then the drug goes directly into the intestine, kicks in 15-20 minutes, and then we have this microdosing for like 16 hours. You take your nighttime drug, oral drug, and go to bed. And then the next morning, hook up the pump again. So this came out like about 8 years ago. It's a phenomenal way to manage Parkinson's disease if that's where we're heading. It eliminates usually the need for oral medication. And then this is the subcutaneous pump. So you can see how much smaller this is. And it is a tiny little, it looks like a port, but it's not a constant port. You prick your skin with that little blue thing over there and pump, again, through a cannula, the drug, which is in a vial in the pump, gives you micro dosing throughout the day. This is 24-hour approval with the ability to go up a little bit if you're more active, like playing pickleball, and then a little bit lesser if you need during sleep. So again, we're talking about constancy. We want constancy, the best we can with constancy. Because if we have constancy, we won't have the cycling of off and on. On meaning I can move, my symptoms are good. Off meaning my Parkinson's is flaring up. I can't walk, I'm slow, I'm stiff, tremor is more. Okay, I'm going to talk about two things and I might stop there. Focused ultrasound is a modality that can be used in Parkinson's disease in which it treats Parkinson's tremor. So we evaluate the patient, and if they have a lot of tremor and the tremor is not always responsive to levodopa, and say the patient has cognitive impairment and we cannot do the other surgery that I'm going to talk about in just a few minutes, this might be a good option to do. There's no cutting, there's no incisions. The neurosurgeon gets an MRI of the brain and passes a beam of ultrasonic light through the skull into the same area of the brain. It's called the STN, the subthalamic nucleus, and dampens the tremor. And it works really nicely. Usually we do it one side, but we could do it two sides. The only problem with two sides is that sometimes it can cause balance issues, so we have to be careful. Usually I'll opt for unilateral or one-sided focused ultrasound procedure, just because we don't want to cause more problems than we need to. But again, it's at our discretion with regards to that. So I'll talk a little bit about DBS. I love DBS in the right patient. It is life-changing, like literally life-changing. So DBS is a surgery in which you put electrodes into a patient's brain, and you're like, oh, you look nice up until now. So nobody's drilling into my head. That's what most of my patients say when I suggest DBS. They're like, nobody's coming near me with a drill. And I'm like, well, you'll be asleep for that portion. But basically, you put electrodes deep down into the brain. The neurosurgeon does that into a predetermined area that I will tell him to go into, and there's only two targets for that, the ST and then the GPI. The STN is very useful for Parkinson's, tremor, and drug reduction, medication reduction. So basically, there are electrodes in the brain connected with a cannula wire, really a wire, and then that is further connected into a pacemaker into the chest wall. And then I have a device, depending on what we're using, that kind of looks like this, and which controls the electricity in your brain. So we can dampen the Parkinson's symptoms by choosing certain areas on that electrode to reduce the Parkinson's symptoms. So the caveat with this is you cannot have dementia. If we implant patients who have dementia with deep brain stimulation surgery, it puts them into a deeper dementia. We don't want to do that. So you have to see a movement disorder physician to make that determination. We do a 3-hour to 3.5-hour long memory test to make sure your memory is good. And if your memory is good, your symptoms are responsive to levodopa, you're not the atypical Parkinson's or the Parkinson's mimicker, this surgery is amazing. So you do need a good neurosurgeon though, because I need him or her to put it in the right spot. And as long as they put it in the right spot, my programming is easier. So there's 3 different devices available in the United States. One is this one, the Boston Scientific. There's Medtronic, and then there's Abbott. And we use all 3 pretty regularly. They all work great. So that's kind of about DBS. A little few things if I were to tell you, just like talking points about what you can do for yourself to slow down your Parkinson's disease. There are 0 drugs. There is nothing. We have 0 medications that can slow down Parkinson's disease. In my career at Banner Sun Health Research Institute, we've had at least 7 different trials over the last 11 years trying out drugs that might slow down Parkinson's. Nothing has panned out. The only things that slow down Parkinson's disease that we have seen in a rodent model is exercise. We want 3 to 4 days of exercise, about 30 to 40 minutes, depending on your health, of good cardiovascular activity. And you're a superstar if you add in 1 day of a balance exercise. So I would say if there's one thing you wanted to take away from here, 2 things. 1, find a good doctor who will be able to really take care of you. And 2, exercise, exercise, exercise. Remain active. I tease my patients with this one. It's like, you don't have an excuse. A lot of you are retired. We have to put this effort into ourselves, right? It's just part of what we have to do. So the recommendations are as follows. We want aerobic, some strength, definitely some balance, and some stretching exercises. There's a phenomenal program called the BIG program. It's a 4-week-long physical therapy program, and it works really, really brilliantly. Okay, how are we doing on time now? Because I know you guys wanted a little bit of time for your presentation. Okay, we should stop here.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.